Welcome to Expert Perspectives, the potential impact of molecular profiling on improving clinical outcomes for advanced non-small cell lung cancer. I'm Corey Langer, the Director of Thoracic Oncology at the Perelman Center for Advanced Medicine, University of Pennsylvania. And with me today is Helen Ross, Director of Thoracic Oncology for Mayo Clinic, Arizona. We're going to have a discussion regarding this topic, but preceding that, Dr. Ross will give a brief slide summary of guideline recommendations from the ACP, ISLAC, and AMP on this very timely topic.
So I'm going to summarize the guideline recommendations from the ACP, IASLC, and AMP for molecular testing. The guideline asks us who to test. Patients should be tested for EGFR and ALK to select frontline therapies with EGFR and ALK TKI treatments. Clinical characteristics should not determine testing. EGFR and ALK testing are recommended for any lung cancer with an adenocarcinoma component. Squamous cancers may be tested depending on clinical characteristics, and primary or metastatic sites may be used for testing. When should this testing occur? At initial diagnosis of advanced stage disease, at diagnosis of earlier stage disease, which is encouraged, to prioritize tissue for EGFR and ALK testing. Results should be available ideally within 10 working days, and specimens that need to be sent to referral labs should be done so within 3 working days. How should EGFR testing be done? FFPE, or fresh, frozen, or alcohol fixed samples are amenable to PCR testing. Cytology or tissue blocks are also acceptable, but we should avoid decalcification, acid, or metal fixatives as they damage the DNA. Each laboratory should establish its own minimal cell number, and the tumor content of each sample should be assessed by a pathologist, and the sample should be microdissected as needed. Any validated EGFR testing method can be used. Testing should be able to detect mutations in samples with at least 50% tumor cells. The mutation testing method should be able to detect all individual mutations occurring with at least a 1% frequency. T790M should be able to be detected in as few as 5% of cells. IHC and or FISH testing are not recommended, and KRAS mutation testing is not recommended for determination of EGFR TKI use. How should ALK testing be done? ALK-FISH using dual-labeled break-apart probes should be done. IHC may be considered as a screening method prior to FISH. RT-PCR is not recommended as an alternative to FISH. A pathologist should be involved in selection of sections for testing and interpretation of results, and secondary mutation testing is not currently required. What about other considerations? Prioritization should be for EGFR followed by ALK due to prevalence. Reflex testing algorithms should be considered for efficiency, but the overall goal turnaround time should still be met. Reports should include an understandable results and interpretation section. Testing validation should follow other molecular diagnostic test SOPs, and the quality control and quality assessment policies should be rigorously met.
Great. I'd like to dive straight in, at least in advanced non-small cell. What are the current guidelines? Who do you routinely test?
The current guidelines suggest that all patients with a new diagnosis of metastatic disease should be tested, particularly if they have an adenocarcinoma component.
Regardless of their smoking history?
Regardless of their smoking history. If we fail to test current smokers, we will miss a substantial portion of mutated patients.
And what about squamous cell?
Squamous cells can be tested depending upon the patient characteristics. So a certain proportion of younger squamous cell patients or with light smoking histories may be tested as well.
Do you foresee a time when we'll be testing everyone routinely?
I think if I'm going to speculate about the future, there will be a time when we're doing the equivalent of next-gen sequencing on everyone and we won't be doing these individual tests.
But at least for now, with the exception of EGFR, ALK, ROS, perhaps a smattering of other less common tests, mostly in the province of adenocarcinoma, we don't really have specific molecularly derived treatments for small cell or for at least most squamous cells. So we're not quite there. Is that a safe?
I think that we're not quite there for current practice, yes.
Do you test reflexly? In other words, can the pathologist actually do the test without a specific order, or must an order from a medical oncologist or another member of the oncology team be submitted?
We have a standard SOP for testing, so if a sample comes in that's clearly a lung cancer sample, then the pathologist can test reflexly. And our algorithm is to test for EGFR first, followed by ALK, and then ROS1. But it depends a little bit on the patient characteristics. If a patient is very ill and the disease burden is high, then we'll sometimes do all of the tests concurrently because we do want to keep the turnaround time as short as possible.
What is your turnaround typically?
Typical turnaround time for EGFR testing is 7 days or a little bit less, depending on the day of the week that the sample comes in. You can add another 3 to 5 days for adding ALK testing on top of that, and then ROS1 another 3 to 5 days.
Some in the past have promulgated the notion that you can do KRAS first, and then if that's positive, you're done because it's unlikely that you'll have double mutations or any actionable mutations. You don't subscribe to that approach.
I don't. I think that that's a nice paradigm for cost effectiveness because you're getting things out of the way with the 25-30% of patients that are RAS mutant. But at the end of doing a RAS mutation study, 7 days have passed and the patient doesn't have an actionable mutation test.
Do you test everyone with non-small cell, or at least with the provisions that you mentioned, or strictly recurrent or advanced patients at diagnosis?
We certainly test all of the recurrent and advanced diagnosis patients. If there's enough tissue, we tend to test everyone, quite frankly. And sometimes we're just banking that information for the future. Sometimes we're using it for clinical trials eligibility.
You mentioned the clinical trials. There are now clinical trials in earlier stage disease that are based in part on EGFR and ALK status. The Alchemist trial, the Intergroup or NCTN Alliance trial. Can you talk briefly about those?
So these are very important trials, particularly Alchemist, which is certainly the highest priority trial in early stage patients. Patients who are resected, we don't really know what the role for adjuvant targeted therapies is in these patients with mutations, and there are certainly some data in unselected trials suggesting a detriment. It's very important to do studies to try and clarify that. And so testing these early stage patients and putting them onto the Master Alchemist protocol so that they can be randomized to EGFR TKI or ALK-directed therapy will help to answer this crucial question that may really be a life-sustaining question for many of these mutated early stage patients.
We've seen data, at least from the Radiant trial in the mutation-positive group, that there was at least a PFS benefit for the EGFR mutant group. It's quite a striking benefit. It was about 20 months, although at least to date that has not quite translated into survival benefit. But the numbers were small.
The numbers were small, and the difference really is striking, and the difference between that enormous PFS benefit and the really no overall survival benefit at this point may simply relate to the early stage of the patients and the good prognosis of those EGFR mutated patients when they do relapse.
Which platform do you typically use for testing?
Our pathologists, I think, change that from time to time, and truthfully, I'm not sure that it matters as long as you're doing a validated test that covers the major mutations. I think that that's what's most important. We know that the FDA is now asking for companion biologic testing to be done as new drugs are approved, and I think that we don't want to be in the situation where a single sample has to be tested with a half a dozen different tests because that's what went on with the drug in question. So I think as long as the CLIA lab has validated the testing and that the results are reliable and reproducible, it doesn't really matter so much what platform is used.
Outside of research or academia, which approach would you recommend? Most community institutions don't really have internal testing apparatus set up. They must send out. So
yeah, that's true. There are a lot of big pathology laboratories that are very well run with a very quick turnaround time, and I think that one could use any of the major path labs across the country.
And the results, at least for mutations, would probably be interchangeable.
Yes, I would say so.
Mm-hmm. What about liquid biopsies? The notion that we can detect not just circulating tumor cells, but circulating DNA and test the blood, saving us the necessity of repeat biopsy or invasive procedures. Where are we with that?
This is a great question because it's one of the biggest frustrations. The biopsy sample is small. It came from an EBUS, for example, and the pathologist has already used it up doing every immunohistochemical test known to man, and so there isn't enough tumor tests.
Tissue's depleted.
Tissue is depleted. And I think that there's a great deal of interest, obviously, in making liquid biopsies work, whether it be in circulating DNA or in tumor cells that are circulating in the blood. And when you get a mutation diagnosis in those patients, they seem to be very specific. The problem is that it's not sensitive enough, so I think it's not ready yet.
Most of the recent data, of course, for EGFR TKIs have focused on the mutation-positive group. You did a wonderful talk today on the much broader group of unselected patients, and certainly there's a lot of controversy there. But we do have trials, including BR21, in an unselected population, including smokers, folks with squamous cell, males, and then, of course, the Saturn trial that did show a survival advantage, granted against placebo, but still a survival advantage. So where do you see the future for unselected patients, and specifically, where do you see serum testing, looking for serum proteomics as used in the PROS trial? If you could talk briefly about that.
So the PROS trial, of course, stratified second-line metastatic patients by the VeriStrat assay into good and poor, and showed really that the VeriStrat poor patients shouldn't be subjected to EGFR TKIs because they did poorly. There was clearly an advantage to chemotherapy. But in the patients that were stratified good, there seemed to be not as much difference between chemotherapy and erlotinib, and certainly not a statistically significant difference. So if there's a reason to avoid chemotherapy in someone who has tested good, then it's a reasonable and acceptable alternative to use
at least gives you
TKI,
equipoise for either chemo or an oral agent like TKI. And I would think that the serum proteomics that we talked about, at the very least, is a negative discriminant. If it's a poor test, then we can probably safely, reliably, comfortably abandon the TKI in that patient.
Yes, I think that's very true, and it is useful, particularly for patients who may live far away from the treatment center, for example, and would prefer to have an oral agent.
Do you think there are any other markers beyond mutation that can help us determine who amongst unselected patients might benefit from TKIs?
I am certain that there are some. I'm not certain that I know yet what they may be. There are a number of things that are in testing. The epithelial to mesenchymal transformation has drawn a lot of attention, and there's some preclinical data that suggests that this may be useful, but none of the rest of this is ready for current practice.
You don't think that perhaps a constellation of KRAS wild type, EGFR positive, EGFR FISH positive might at least detect a group that we're not going to harm, but perhaps there might be some benefit, or
I don't know what the advantage of that constellation would be over other methods of testing, and it's more tissue.
Finally, regarding squamous cell, there is a major push to do genomic sequencing. That has actually been nationalized. There is a NCI-sponsored trial, the lung cancer master protocol for squamous. Can you talk a little bit about that and where you think what the therapeutic implications are in at least the second line setting?
The master protocol is sort of on the other spectrum from Alchemist. It's a very high priority trial that all of the cooperative groups have signed on to, and it's taking advantage of a uniform patient population for whom there really isn't a defined target now, taking the patients with the same eligibility criteria and then assigning them to different treatment baskets, I think somewhere around 5 or 6 at this point, based on the molecular analyses, particularly things like PIK3CA, which may be important in squamous cancers. And in contradistinction to Alchemist, for patients who don't have a target in this sort of speculative assignment to baskets, those patients will go on to an immunotherapy protocol. So everybody that enters the protocol will have a protocol-directed treatment. And again, this has been endorsed by all of the cooperative groups. It's a very high priority trial.
So at least it's a uniform effort to type and molecularly define the squamous population. We really haven't had that. There's so many mutations that have been defined, but we really haven't had a defined action plan for those mutations. And doing a protocol like this will enable us to learn a lot much more quickly than doing a series of 6 individual protocols. So the study may or may not help us determine which of any of these are truly actionable.
Absolutely.
And which agents may actually work on them. And of course, we're disadvantaged by the fact that unlike adenocarcinoma for the most part, many of these molecular abnormalities are not mutually exclusive, that they can occur in tandem. So
that's exactly right, and figuring out which is the most priority one is going to be very difficult. But the other nice thing about this study design is that the buckets can rotate. So the study design can be altered. If one arm is abandoned, that arm can be replaced without changing the whole protocol. So this is, we hope, very efficient.
Well, I want to thank you very much. This is Corey Langer thanking Helen Ross from Mayo, Arizona for her expert perspectives on the potential impact of molecular testing in affecting clinical outcomes in non-small cell lung cancer. And thank you for your attention.